We have always, as a physician, we always listen to the patient, we always question the patient, and we always educate the patient to share the expectation. Interestingly, the patients are kind of very shy in saying they want this, they want that, etc., because efficacy and safety has always been what they have been sort of educated into being the most important markers for them to consider to survive. Myeloma is a deadly cancer in the end. And as you pointed out, it's very interesting to see that now with the COVID, and while we are sort of exiting the COVID, hopefully, the patients are having different view of how to manage their treatments. They are, first of all, voicing what they think, what they want, their fear, their objectives, much more than before. It's one thing very interesting. So possibly it's different in Europe compared to the US. Maybe in the US they voice more because they are more educated to do so. But in Europe it's something new. And beyond voicing, they also clearly state how much they want quality of life being part of the decision making of what type of treatment they're gonna get. And how we make that decision on the treatment they're gonna get. So by quality of life, we often think side effects, adverse events, but that's a very poor view of what quality of life is. And actually, it's not the view of the patients. The patients clearly wants to go back to normal life. Normal life means, of course, as few adverse events as possible, but it also means coming to the hospital as rarely as possible, coming to see us physicians as rarely as possible, doing biology test labs as rarely as possible. And it's very interesting how the COVID has changed our way of working, our vision of life, working professionally and life, but also for the patients. And there's a new marker that is integrated now. Efficacy, safety are still, of course, the two greatest driver of the way we treat the patients. But now the patients is much more implicated, and quality of life in its global meaning is a new driver and almost at the same level as to efficacy and safety. So myeloma is a complex disease, there's a lot of relapse. If you are earlier, it's really truly where we see quality of life being a key driver. Of course, if the patients are more advanced, the quality of life is less a driver because efficacy is more a primary element. But it's very interesting to see how the COVID has had terrible impacts, but maybe also some indirect good impacts. So that's for the new way of appreciating the patient perspective, and a series of studies are now showing this very nicely. Now, the patients are also asking for being more educated, let's put it this way, which it's something I know, for example, because when I was working in the US, I've seen all these patient-physician meetings and how the patients are looking for information everywhere, constantly. It's the same in Europe, but not to the same extent at all. And because they are not finding easily this information, and because we are not necessarily providing very prospectively this information to them, because we are not necessarily educated this way. Now it's changing also. The patients want to know how the other patients that have been through the same treatment are faring and feeling, and how they suffered or how they survived and how they're doing. And it's also interesting to see how, whether it's related or not to the COVID, this I'm not so sure, but it's now, it was not before, so maybe it's related to COVID, and how now, these days, we clearly see that real-world evidence data matters to patients, not just clinical trial. Similarly for us, real-world evidence data more and more matter in parallel, complementary to clinical trials. We need the clinical trial data for the drug to be approved and to know globally about a drug or a new regimen or a new schema, and to change the treatment or to anticipate changing the treatment. But we need the real-world evidence to make sure that it is applicable, these changes would be applicable to all patients, all subgroups, including patients that rarely are represented into clinical trials. And I'm particularly talking here of patients with some degrees of frailty, renal insufficient, frail patients, but sometimes very young patients or very old patients, and sometimes patients that live far away from the hospital. And I would not go in a clinical trial because they can be treated normally close to where they live. And if they had to participate in a clinical trial, they would have to travel a lot to, for example, my center. So it's very interesting to see how these real-world evidence data that we have created for years and no one cared about pretty much, finally seems to really get appreciated for what they are valuable for. We appreciate that they are biased, but the clinical trials obviously and clearly are immensely biased, although it's different. And so yesterday in this very interesting Takeda symposium, I think we concluded that we should not oppose, but clearly real-world evidence data must now be complementary to clinical trials, and that for each drug, when the clinical trial is wrapped up, we need to have real-world evidence to validate what we found into the real life.